Now, after having discussed the basic concept about nephrotic syndrome, let us discuss the three important primary causes of nephrotic syndrome, that is minimal chain disease, focal segmental glomerulosclerosis, and membranous nephropathy. Now, what I thought was that all three of them are chapters by itself. So, what I thought was discussing them separately would actually multiply our efforts into three. Why not study them all of them together in a tabular format, because I love tables, so that our effort will be only once and our output will be thrice. Let us try it once. So as I said, what is the age group? What is the age group that each one of them presents in? Now, minimal chain disease is most common in children. Focal segmental glomerular disease is the glomerulosclerosis is the most common cause of nephrotic syndrome in adults. All of them are MCQs, whereas membranous nephropathy is most common in elderly. It itself is an MCQ. Now, what are the causes of all of them? Now, the very important, what is the primary cause of minimal chain disease? It is basically idiopathic. Had it been their cause, it would not have been named as primary. Again, the primary cause for FSGS is idiopathic, and membranous nephropathy also is idiopathic. Though there have been some important causes and etiopathological factors related to each one of them, which I shall discuss it. Coming to secondary causes of each. Now, let us begin with first and foremost drugs. So, what are the drugs that cause minimal chain disease? The important drugs are rifampicin, interferon, NSAIDs, and lithium. Now, because it is very common in children, and children obviously like to play in the dirt, so when the children's clothes will become dirty, they will go to their mothers, and their mothers will have to wash them with this. And of course, when they make their clothes repeatedly dirty, their mothers will give them this. I hope you understood. So you could remember it with a very easy mnemonic, that is Rin-L. And all of them are important MCQs, mind you. Coming to FSGS. Now see, FSGS is a very, very notorious entity. Why? I would like to tell you for 2 to 3 reasons. Because it is a very notorious entity because it is associated with a very bad infection, because it does all the bad things, and that is why it stands from a distance and smirks at the patient. And I always feel that it is very, very happy. It is very, very happy. And because it is very, very happy, why is the reason that it is happy? Because it is caused by drugs like heroin. So he has done heroin, and that is why he is happy. Also, A for analgesics, P for pamidronate, I for interferon. Now, if you have to mark one disease for interferon, you will mark FSGS, because interferon association with MCD is rare, is uncommon, though it is reported, but FSGS is a more common entity which is reported with interferons. Now, also certain other drugs that can be associated are tyrosine kinase inhibitors and anabolic steroids. I told you it has done all the bad things. It has done heroin, it has done anabolic steroids, and that is why he is happy. Now, coming to membranous. Now, membranous nephropathy, as I told you, is a disease of the elderly. When you think of elderly, I and you think of our grandparents. Now, if you have ever opened the almirah of your grandparent, you will see that they keep a lot of this in their almirah. Because they are often hypertensive, That is why they also have an instrument to measure the blood pressure, which is made up of this. So, gold and mercury are two very, very important elements that cause membranous nephropathy. Now, another congener of gold, which was actually an anti-rheumatic drug, was D-penicillamine. And these are the old drugs that were used to treat rheumatoid arthritis. And both of them caused membranous nephropathy. Now, another thing, elderly are often hyperuricemic. And to treat their hyperuricemia, many doctors might prescribe them this drug. So, it is also the probenecid that is associated with membranous nephropathy. It is just these lame things that I am trying to, make you remember the name of the drugs which are associated with each glomerular disease. So after drugs, let's come to the next important secondary cause, that is infections. Now with regard to minimal chain disease, no important infections with respect to MCQ are there that are associated with MCD. Now with respect to FSGS, I told you it is a very notorious chap. It is smiling, it has done heroin, it has taken anabolic steroids, and due to bad techniques and bad means, it has contracted this infection. It has contracted HIV. The patient who does IV drug abusers, of course, is more prone to HIV. Again, when he is an HIV patient, of course he will have opportunistic infections like cytomegalovirus, like simian 40 virus, SV40. Also a parvo B19. So all these four infections are associated with focal segmental glomerulosclerosis. And not to forget, when I shall discuss the histopathological types of FSGS, I shall tell you that there is a very bad variant of FSGS which is known as a collapsing variant, which is associated with FSGS. And obviously it has a worst prognosis. Coming to infections associated with membranous, we have the hepatitis B, we have the hepatitis C, we have the schistosomiasis, we have the leprosy, we have the syphilis, and even tuberculosis is reported to cause membranous nephropathy. So all these infections are associated with these three disorders. After infections, come to malignancy or cancers. Now, important malignancy associated with minimal chain disease is very, very important: Hodgkin's disease. Hodgkin's disease. In fact, a question can be asked even in the medicine part. Most common glomerular lesion associated with Hodgkin's disease is membranous nephropathy. Minimal chain disease. Minimal chain disease. So most common glomerular disease associated with Hodgkin's disease is MCD. And what happens here is, there is a protein which is known as c-MYP protein. It is overexpressed in the Reed-Sternberg cells in Hodgkin's disease, and it causes podocyte injury. So if you are ever asked a pathogenesis, what is it? It is overexpression of the c-MYP protein, CMIP protein in the RS cells, in the Reed-Sternberg cells, which cause podocyte injury and thus causing minimal change disease. After Hodgkin's disease, we have the mycosis fungoides, which is the cutaneous T-cell lymphoma, and rarely thymoma is said to be associated with minimal chain disease. Now, why am I saying these things in so details? Because Hodgkin's has already been asked twice or thrice, and you can very well expect the rest of the cancers to be asked. Coming to focal segmental glomerulosclerosis, very important malignancy here is the Here you have the Hodgkin's, so here we have the non-Hodgkin's lymphoma. Coming to the membranous nephropathy, lot of cancers are associated with membranous nephropathy, especially the solid tumors. And this has been asked very many times, that solid tumors are associated very commonly with which glomerular disease? Answer is membranous nephropathy. And what are the cancers? 4 very important: 2 supradiaphragmatic and 2 infradiaphragmatic. The two supradiaphragmatic are CA lung, CA breast, CA colon, CA ovary, the infradiaphragmatic cancers. And very important, CA prostate. CA prostate. Other not so common cancers are melanoma, neuroblastoma, and chronic lymphocytic leukemia. But if we are asked which are the in fact most common cancers associated with membranous, answer is CA lung and CA prostate. CA lung and CA prostate are the most common cancers associated with membranous nephropathy. Very important. And if we are asked that CLL though is associated with membranous, but it is most commonly associated with which glomerular disease? It is most commonly associated with membranoproliferative glomerulonephritis. So we are discussing a lot of information here. Please be very careful while we are discussing this. Now, after we've discussed drugs, infections, malignancy, what is the next important cause? Coming to autoimmune diseases. Well, common association, I would not say common though, the disease is common but the association is uncommon, of MCD with autoimmune disease would be systemic lupus erythematosus. While discussing SLE, please go back to that video and read that we have discussed there is an uncommon variant of association of MCD with SLE, and that is known as lupus podocytopathy, which is very responsive to steroids. Coming to FSGS, we do not have important autoimmune associations of FSGS, but membranous has a lot of autoimmune diseases that cause secondary membranous nephropathy. What are they? They are very important. The lupus nephritis class 5. We have the rheumatoid arthritis. We have the Hashimoto's thyroiditis. We have the primary biliary cirrhosis. We have even the sarcoidosis. So these are the very important autoimmune disorders that cause your membranous nephropathy. Coming to genetic causes. Genetic or inherited causes of minimal chain disease, there are none, to be very honest, none that important or that can be asked in MCQ. Again, with regard to FSGS, yes, it is the very important, lots of inherited causes of FSGS, which is known as familial podocytopathies, which we have also discussed while discussing nephrotic syndromes, which can be again the nephrin, the podosin, the Wilms tumor 1, the Dennis-Drass syndrome. In fact, all these inherited causes of nephrotic syndrome are FSGS on biopsy, and they are actually the steroid resistant nephrotic syndrome, or SRNS. With regard to membranous, not any important genetic or inherited cause of membranous. Last but not the least, what are the miscellaneous causes of the three? Very important miscellaneous cause of minimal chain disease is allergens. Important allergens have been associated with minimal chain disease, like the pollens, like insect bite, like the poison oak. In fact, even the home dust is said to be important in the etiopathogenesis of minimal chain disease. With regard to the membranous nephropathy, important miscellaneous causes are the graft versus host disease after hematopoietic stem cell transplantation. It is the GVHD, and which has already been asked that GVHD leads to which glomerular lesion? Answer is membranous nephropathy. Now, FSGS has a very, very important miscellaneous causes. I've had to put it in the miscellaneous category because I was nowhere finding to put it elsewhere. This is actually the maladaptive structural or the functional response of the body. The maladaptive structural functional response, which cause actually the secondary FSGS. So basically, pathogenetically, the maladaptive, as you can understand, it was an adaptive response of the body to something that was not physiologic. So if it is a maladaptive response to reduce renal mass, which basically means there were decreased functioning nephrons, or there is hemodynamic hyperfiltration injury on initially normal kidney. So if you have the reduced nephron number or the reduced nephron mass as a maladaptive response of the kidney, you can have FSGS. Like if there is a patient of very low birth weight, if there is unilateral renal agenesis, if there is renal dysplasia, if there is oligomeganephronia. So there are reduced nephron numbers here, and that is why the patient is having this. If the patient is having a post-nephrectomy status, be it a donor nephrectomy or due to a nephrectomy due to any infection or even a cancer, patient having a reflux nephropathy, or even a patient of any advanced renal disease. In fact, this is very, very important to understand, because actually FSGS is not a single disease entity. It is actually the culmination of any advanced kidney disease. Every advanced kidney disease culminates into focal segmental glomerulosclerosis, which is very, very important. Even the chronic allograft nephropathy, which we often abbreviate as can terminate into focal segmental glomerulosclerosis. Now, on the other hand, if there was a normal renal mass initially, and but due to some other conditions, the patient had a hemodynamic stress on the kidney, the patient started hyperfiltration to compensate and ultimately landed in FSGS. What are those conditions? Very, very important. Obesity, hypertension, sickle cell disease, atherombolism, cyanotic heart diseases. So here, these are basically those conditions where there is the functional hypoxia of the kidney leading to hyperfiltration and leading to hemodynamic stress on the kidney and eventually damaging the kidney, causing FSGS. So these are all the causes of MCD, FSGS and membranous written together. And just before we move on to the next topic, I would just like to revise and brush up these causes once again. So the drugs that cause MCD are basically the Rin-L, child, dirty clothes, Rin-L. FSGS was very, very happy. So heroin, analgesic, pamidronate, anabolic steroid, tyrosine kinase inhibitor and the interferon. Elderly person, gold, mercury. You have the probenecid, you have the D-penicillamine. Coming to infections, no infection as such here. Here you have the happy, notorious child due to heroin and HIV, parvovirus, CMV, SP40. Again, coming to membranous host lot of infections, hepatitis B, hepatitis C, schistosomiasis, leprosy, TB, and all those infections. Coming to cancers, we have the Hodgkin's lymphoma, non-Hodgkin's lymphoma, solid tumors, most common lung and prostate. Autoimmune diseases, lupus podocytopathy, nothing great with FSGS. Host lot of autoimmune diseases, that is systemic lupus erythematosus, RA, Sjogren's, primary biliary cirrhosis, Hashimoto's thyroiditis. Genetic cause, inherited causes, not much, but the prototype is focal segmental glomerulosclerosis, that is the familial podocytopathies, nephrin mutation, podosin mutation, the steroid resistant nephrotic syndrome group. Last but not the least, the miscellaneous causes. Here you have the pollen grains or the allergies, the poison oak, the house dust. Here you have the graft versus host disease, and very, very important, the miscellaneous causes of the FSGS, which are the maladaptive responses, either to initially functioning mass or to reduced nephron number. If the kidneys number is low, for example, the kidneys has been taken out, that is post nephrectomy, the kidney has not developed renal agenesis, there is a very low birth weight, so there is reduced kidney numbers, there is a renal dysplasia, again a developmental disorder, there is a chronic allograft nephropathy or any advanced renal disease. On the other hand, there is a normal initial kidney, but there is an increased hemodynamic hyperfiltration injury due to obesity, due to sickle cell anemia, due to cyanotic congenital heart disease, or due to hypertension, will lead to FSGS. So these are the important causes of all the three glomerular disorders.